The sixth theme is being debated by Dr. Ashish Kumar, a young cataract and cornea consultant from Patna, which is now the hot seat of India as it is going for elections. And we'd like to contest with Dr. Jayesh Wazirani, a proficient and young cataract and cornea surgeon who will be talking on for Fuchs and cataract, a combined procedure, versus Dr. Ashish, who will be saying, no, it would be staged procedure. Over to Dr. Ashish, please.
Dr. Namrata, we'll be needing you to comment on these cases.
Yeah. Thank you so much for the invitation. It's an interesting debate going on, learning a lot. We encounter these cases every day and there's a lot of confusion. Thank you for conducting this. My topic for today is Fuchs and cataract, and my treatment of choice would be stage procedure always. My slides are visible?
Yes, sir.
Yes.
All right. Okay. So look at the possibilities of doing a stage procedure. It gives you enough, it gives you enormous possibilities. Like if the patient has just a cataract and not much of Fuchs, not causing much corneal edema, you can just do a cataract surgery. And if required, DMEK and DSEK can be planned at a later stage. And then if needed, cataract surgery at a second stage, especially in younger people. And there are certain cases like where you have a severe subepithelial fibrosis and you like to do a superficial keratectomy before you do a DSEK and DMEK. So if you do a stage procedure, you can do all this. So biggest advantage of the stage procedure is that you may never need a second stage of the surgery. And with the Descemet stripping only and rho kinase inhibitors, these patients may never need a keratoplasty at all. So the most important thing is what is the timing and the type of surgery you do. Success and safety of endothelial keratoplasty has resulted in lowering of the threshold for intervention compared to when PK was the surgery of choice. Nowadays, people are doing EK for just removal of the guttae. And this was not possible when PK was the only choice. Still, we use central corneal thickness and endothelial cell count as a surrogate marker for endothelial cell health. And this is how we decide whether we want to do a combined surgery or a stage procedure. But this at times can be misleading. This is a specular image from a single patient. If you see three different places, you have three different readings. So you cannot rely on specular images for deciding cataract surgery or a combined surgery. So recently, Scheimpflug tomography has been considered to be the most relevant indirect measure of endothelial corneal health. CCT, like I said, is used as a guide, and it is seen that if the CCT is more than 640 microns, there's an increased risk of postoperative corneal edema. So if it is more than 640 microns, one-fourth of the patients will need keratoplasty after cataract surgery. But see what you're doing. Almost 3/4 of the patients who may never need a keratoplasty are being subjected to the lifetime risk of graft rejection. So never a combined procedure. Always do a stage procedure and see what happens to the cornea. We can always go back and do a cornea procedure. Obviously, combined surgery gives you certain advantages like less number of surgery and less number of anesthesia exposures. It's a cost-effective and faster visual rehabilitation. But you have to look at the other side. And several studies has compared sequential procedures with triple DMEK, like endothelial cell loss and visual refractive outcome, re-injection rates, and primary graft failure did not differ much between the two. But the main concern with the triple DMEK is the use of viscoelastics during the cataract surgery. And this is the main reason for graft detachment. See, re-injection rates can be brought down from 45% to 16% with the elimination of complete viscoelastics during graft injection. This is only possible when you're staging the two procedures. Because in DMEK, if you're just doing DMEK without cataract surgery, there's no use of viscoelastics. This was a case of, I planned for SICS and DSEK because the cataract was very dense and the pupil was not dilating. It was a PXF. And I thought I'll get away with a small pupil. I didn't want to do any sphinctotomy here because the iris will get floppy and then it'll mess up air injection. Sometimes air will go behind and then the iris will stick to the cornea. So I thought of doing a larger excess under the pupil, and somehow I managed to do it. But see what happened next. The cataract was very hard and I was just struggling to remove it from a small pupil. So this was
1 minute left.
And then I left with no bag. So I have to cancel the surgery. So what are the advantages of lens surgery without keratoplasty? Most importantly, you may never need a keratoplasty. You can put IOL of your choice, toric and multifocal. It's still debatable, but toric is acceptable. you have the opportunity to do PI, which sometimes during combined surgery can cause bleeding, and unfolding of the DMEK scroll will be difficult. You have shorter surgical time, and you can get away with intra-op complications like PCR if you're just doing lens surgery. And the advantage of DMEK without lens surgery, you preserve accommodation in younger patients. Otherwise, these patients will have to wear glasses at a very early age. This is a case of Fuchs with cataract, and I did the cataract surgery a couple of months ago, and then I planned for DMEK surgery, and I'm doing DMEK stripping under the saline, and see here I have done the PI already while doing the cataract surgery, so there's no bleeding while doing second stage of the procedure, DMEK. Then securing the graft, putting the graft inside, unscrolling the graft with the tapping technique. Just a 15-minute procedure. And you're done with the. So when to do DSEK and DMEK again? Now the DMEK is the procedure of choice. When the patient is phakic, you like to do DMEK because you want a shallow anterior chamber. If the patient is pseudophakic, you have a deep AC, you can either do DSEK or DMEK. The procedure of choice is DMEK again now. So my guide to Fuchs and cataract: grade the severity of Fuchs and cataract, try to correlate the symptoms with the sign. If the patient is complaining of just a generalized decrease in vision, just go ahead and do with the cataract surgery. If the patient is complaining, he has a diurnal variation, then do keratoplasty first and then later plan for cataract surgery. Consider the age of the patient. If the patient is young, don't touch the lens, and then determine whether cataract surgery is needed or keratoplasty. So Fuchs and cataract, it's always staged procedure. Never do a combined procedure. Otherwise, you'll be subjecting 3/4 of the patient who never need a keratoplasty. You'll be subjecting them to the risk of graft rejection. Thank you so much.
Thank you, Dr. Ashish. That was a wonderful talk.